Generally, our skin is an encapsulation for the whole body, right? It protects us from a lot of assaults, lot of infections. It acts as a barrier, as a thermoregulator, and a lot of things will go on if I start explaining. But basically, it's a shield for us from the external environment and their hazards. And it is a window through which we can look inside the body. That is, when skin is affected, some part of the system is involved, has to be suspected. That's why we should think that it's a window where we can go deep into the body and consider deeper tissue involvement in the disease. Virtually no disease of the body that does not give itself away on the skin. Almost all the systemic illnesses have skin as a factor. Skin as a factor. And it is considered to be the greatest system which can reveal all the secrets of our body systems. Let us see the broad classification of manifestations. First one is, and the most common one is, endocrinal disorders and metabolic disorders. Equally important, connective tissue disorders like systemic lupus erythematosus, inflammatory disorders like some other conditions like Addison's disorder or such hereditary illness also can be included under inflammatory conditions, and GIT disorders as our classical Grahani manifestations. Renal disorders, one is Addison's disease itself, malignancies, and very commonly in children, vitamin deficiency disorders. Let us discuss one by one, and we'll go through the conditions superficially because deeper aspect we have to deal with the main disorder pathologies, which will not be covered in a near 2-hour session. Metabolic disorders, in that diabetes mellitus. Out of this is a very common feature. If you see the photograph, you can see lot of senior citizens, especially females, with the borderline diabetes or chronic diabetes cases coming into our OP with the hyperpigmented or hyperemic rashes, which are symmetrical distribution coming to our OP. And if we are suspecting the case of this borderline diabetic, we have to manage the diabetes first. It starts with erythematous papules and later they grow into a plaque, and it is very common in females, and the commonest site is anterior region of the lower limb. Shin is the common area of affliction, and it shows a symmetrical distribution. It's a very characteristic feature. If it is symmetrically seen in the lower limbs, definitely we have to consider diabetes mellitus, and we have to manage the main cause illness also. Next is scleroderma adultorum, and this scleroderma, as the name suggests, there are sclero as the presentation is the photo. I hope the photo is visible. The lesion is very predominant on the first photo on the central aspect. If you see the center portion of the thorax and abdomen, you can see a pigmented lesion. And next is the hyperpigmented lesion on the scapular region. It's a very slowly progressing disorder, and it's very similar to scleroderma. And the commonest site is the trunk, and especially on the scapular region and also on the face. It is usually hyperpigmented lesion, and it is mainly due to the deposition of collagen and mucopolysaccharides in the deeper skin layers. For this, we have to manage it in a greater level. That is especially naturally, we may need Shodhana Karma, that too a good Virechana, of course, and then go with the Rasayana. It won't be managed, it is very difficult to manage in the OPD level. So the deposition of collagen is the basic reason of scleroderma. Next is bullosis diabeticorum. A similar lesion, a very similar lesion, just like we discussed that hyperpigmented patch in female, elderly female, which is symmetric in distribution. And this is also a characteristic feature, but only thing is there will be blisters. There will be blisters. At the same time, those blisters will be painless. Those blisters will be painless, and the lesion will grow as well as heal very fast, but it will recur. So a painless bullous eruption is the diagnostic feature of this condition. If there is no bullous lesion, it has to be considered as this one, the necrobiosis condition. And if it is bullous, it is like this. Next is granuloma. Granuloma is usually very much similar to psoriatic lesion, but there are a few things which we have to consider. A psoriatic lesion or psoriatiform lesion which looks like psoriasis, if it is long standing and is seen only on the extremities, and it is not at all resolving on conventional management, we have to suspect an STD or an underlying tumor or a carcinogenic or carcinomatous condition. At times it is occupational also. At times it is occupational also. So we have to consider their profession and also an evaluation which helps in ruling out HIV and tumors. Only thing is we should be managing these conditions in the first line if at all possible. To our OP, usually a diagnosed case comes, and I had seen 1 or 2 cases, but it is diagnosed, so there was no much challenge in it in diagnosing. But if it comes in the first hand, naturally any physician will go towards psoriasis as the diagnosis. So we have to rule out this clinical condition which is related to systemic illness once we have failed in the giving the result to the patient by treating in the lines of psoriasis. This is very common in our OP. We can see the hormonal imbalances. In such conditions, we diagnose these cases as acanthosis nigricans, obese, short-statured, and they have some endocrinal pathology which they are already undergoing treatment, or an unknown the patient is totally not at all knowing that he is having endocrinal disorder. And this is also very common in the cases like developmental delay or Down syndrome. Such cases, we can see an associated feature of these acanthosis nigricans, which is skin thickening beyond an admissible level. Our admissible level, we have to consider a few things in our OP where skin thickening to a level is due to some developmental changes which occur as a secondary development characters, and also their family trait. All these are to be considered. But if at all it goes beyond a level, we have to suspect such clinical condition which are related to the hormones, and it usually precedes the diagnosis of diabetes, a precursor to diabetes. If we see Charaka, anyhow I can't survive without mentioning Ayurveda. Basically, I am a very strong Ayurveda loving person. You can see a cross reference in Charaka where he mentions Vina Pramehamapieta Jayante Dushtamedasaha in Langana Brahmaniya context. Just before that, in if I am not wrong, in Charaka Sutra Standard 20th chapter, there are a few clinical conditions which are related to Medoja Vikara, where the reason is Medodushti and it is a precursor to diabetes. Vina Pramehama Pieta Jayante Dushtamedasaha. In that, the line goes, the clinical presentation is explained in chapter number 22 and 23, Charaka Sutra. If you see, this is acanthosis nigricans is exactly mentioned in that context. It's a precursor to diabetes and normal values. Let us concentrate on the pictures. A case of vitiligo, which we didn't discuss yesterday. We had kept it for today's discussion. An autoimmune disease, and you can see, and it is very easy to diagnose due to its pattern. Yesterday we had a doubt in a small baby who had a hypopigmented macular lesions, which is sparsely distributed on the chin. We suspected why that was not vitiligo, and exactly this is the reason we had not considered that case as vitiligo. The site is very characteristic, and the lesions often affect the extremities, face, and cervical region, as well as the trunk. And in majority of the cases, the lesions are symmetrical and they are quite easy to diagnose. Carotenoderma, a yellowish discoloration of skin and nails, and that are usually due to diabetes. It is usually seen in high diabetic patients, that too chronic diabetic cases. Lichen planus, we discussed yesterday. It's a characteristic lesion which is accompanied by localized pruritus or itching on the ankles and wrists with optional involvement of mucosa. It is self-limiting and easy to diagnose. There will be purplish, discrete lesion spread all over the body, and its characteristic thing is it is self-limiting. In 8 to 9 months, it will go off, but it will recur. Diabetic foot syndrome. It's a combination of diabetic angiopathy, neuropathy, and mechanical, some external trauma, which occurs usually, and that is due to a chronic ulcer or healed ulcer in which a quarter of the patients develop complications such as infections and osteomyelitis if it goes into the deeper tissues. It's usually bacterial in nature, and those infections go much more deeper level, which can later cause osteomyelitis even. We had already discussed the case yesterday, the photographs yesterday of diabetic foot. And if the muscle tissues are damaged, if those infections go further, the bone tissues will also be affected. Skin infections. Recurrent skin infections should be a reason for investigating diabetes mellitus. This statement I had directly taken from the textbook. For those who want to have or who have keen interest in practicing dermatology, one thing we need to have an atlas. A good atlas should be procured, and also a book which explains the cases in Indian perspective. In Indian perspective, we have a lot of textbooks. We can opt the cases which are explained and which have photographs of Indian cases, because rarest of rare possibility cases which are not seen in India, but we keep on learning and we won't see the case throughout our life, throughout our practice. So better to follow a textbook written by an Indian author who is a very good dermatologist practitioner, whose explanation is much more easier to follow. So I had taken from one such textbooks the same sentence copied. Recurrent skin infections should be a reason for investigating diabetes mellitus. Out of this, pyoderma, folliculitis, abscesses, and impetigo we already discussed. And if a patient is chronic diabetic, he can develop all these three clinical conditions recurrently. Recurrently. Already we discussed streptococci are the usual culprits behind these infections, and a few cases are due to this staphylococcus also. Candida albicans is the most prevalent pathogen, and it can affect the skin and mucous membrane as well as the preungual region. That also photographs we had seen yesterday as a part of our nail infection cases. Onychomycosis and paronychia are the two clinical conditions where nails will be brittle and there will be a sort of sediment beneath the nail. This is a very common presentation in the case of a diabetic patient. And it's a fungal infection and it's very common in diabetics. Complications of anti-diabetic therapy is another area, which is mainly due to insulin. You can see hyperpigmented patches on the area where the patient had has been taking insulin in a common single site. They may develop such rashes, and anaphylactic reactions are also very common. And local reactions like urticaria and eczema are also very common in such diabetic therapy patients who are undergoing treatment for diabetes.